Thank you very much for inviting me. It is a great honor. Thank you for the organizers. And this has been really well planned, and I enjoyed really all the lectures from other colleagues. Congratulations to them. And it is also a privilege to honor Professor Roton, because he's done a work which is tremendous. And this work has helped all surgeons and neurosurgeons in the world to understand better the anatomy, and of course, to treat patients safely. So he has, through his work, operated so many patients worldwide because of his work. I met him personally once in San Salvador, he's a fantastic man, and I think everything has been said, but it's important to remember and to remind that. Okay. In fact, some of my slides are taken from his slides he made, and I've also borrowed some slides from Professor Campero so that I can explain these. Okay. So I'm going to talk the far lateral approach to the foramen magnum. As you can see, this is Professor Roton, and foramen magnum. It's theoretically is a very straightforward operation, but on condition, you know very well the anatomy and you know the landmarks. I'm going to try to show that, to demonstrate that. This is the typical MRI we can see, which is showing that we have a problem into the posterior, into the foramen magnum. How do we define where is the foramen magnum? Is basically the foramen magnum is divided, is separating the cranium from the upper part of the cervical spine. And anteriorly, you can see that is made by the lower 1/3 of the clivus and the posterior aspect of C1 and the dent or the odontoid dent. And posteriorly is made of C1 lamina and also the posterior part of the occiput. And from surgical point of view, you can see in this slide that which is showing the area where any pathology which is found on that green area is actually that pathology, showing that it is a pathology of the foramen magnum. Now, anatomically, that's the aim when you do your dissection, is to be able to identify those structures. It means the horizontal part of the vertebral artery. We can see the condyle just anteriorly. You can see the condyle just anteriorly. In any way, I will go into detail later on so that we can see exactly what we want. It's just to show what we need. We need to attend that. The most important structure to find is actually this horizontal part of the vertebral artery. Now, usually, here again, we'll go into detail. It is on the triangle called the suboccipital triangle, which is made, I'm trying to get my arrow, which is not showing, yes, which is made here by the rectus posterior major muscle, the inferior oblique muscle, and the superior oblique muscle. And actually that part of the vertebral artery will be found in between here. And when we do further dissections, remove the fat tissue, you can see that you can here recognize again the structures, and we can see here the rectus posterior major, the inferior oblique muscle, and the superior oblique muscle. Okay. Here, what we see here is the rectus posterior minor. Here again, once you remove those muscles, you can see very well the artery, which is here. And below here, we have the inferior oblique muscle. Now, to get to that area, we have to expose 4 layers of muscles to get to the triangle, 4 layers of muscles. And as you can see here, the first layer is made by trapezius muscle you see here, and the sternocleidomastoid. That's the first here. That's the first layer. And you see that those muscles are inserting themselves to the linea nucale superioris. And it's very important to know. The second layer is made by plenium muscle, which is also attached to the linea nucale superioris. The third layer, as you can see, is made by the semispinalis capitis and also attached to the superior linea nucale superioris. That constitute the first 3 layers. Now, the fourth layer, you can see, is made by this is what you see, rectus posterior minor, okay? Then it is made by the rectus posterior major, the inferior oblique muscle, and superior oblique muscles, which is very, very important, interesting, because in between then, that's where we find the vertebral artery. So this triangle is very important. You do all the dissections as soon as you can identify this triangle, because that's the one which is going to show you where is the vertebral artery. Can you still hear me?
Yes, perfectly, Kazadi.
Yes.
Thank you very much. Okay. And this is the kind of incision I prefer, but you can do other incisions as well. As soon as you can identify that triangle, which is very, very important. And that's it, usually the incision. Once you dissect, you get now to the linea nucale superioris. And you see that on the linea nucale superioris, and you have the muscles which are still attached to the skin. That's very important. And when you do further dissection, you get down to the linea nucale inferioris, which is about 2 centimeters from the linea nucale superioris. And from here, you start to dissect, you leave the muscles to the cranium, and you start to dissect the skin until you get now you can see now the triangle we're talking about, which is the triangle here, because you know that in between, that's where you're going to find the vertebral artery. You see here the vertebral artery, and you see the posterior arch of C1. And when you do further dissections, you can see that when you remove the rectus posterior major and oblique superior, you can see now very well the posterior arch of, you can see the posterior arch of the C1, you can see the vertebral artery, and so you can see further there, but I'll show it much better in another slide, the condylus. You see here the condylar, and here this is the outline of the craniotomy, which will be done further later on. You see the craniotomy has been done. We can see here the occipital condylar. We can see here the vertebral artery, and of course we can see here the posterior meningeal artery. Now, the opening has to follow the medial limit of the sigmoid sinus and coming down, looking for my, medial aspect of the sigmoid sinus coming down to the medulla and lateral to the medulla, so that you can expose very well this part of the area. As you can see here, Once we've drilled the condyle, we have much more space. I will show that in another slide. Here we can see very well when the dura has been opened, we can see very well the posterior inferior cerebellar artery, which are, and then the medulla cervicalis. You can see very well. And this is, you can allow to have this space when you've drilled the condyle. Now, you'll hear also the literature that there is a debate between to approach the pathologies on this area, either on the retrocondylar approach or transcondylar approach. Generally, with the retrocondylar approach, there are those lesions which are lateral and also posterior. But those which are lateral and going anteriorly, it's better to go transcondylar because then you have more space to get there. Here, it is, the opening of both sides, craniotomies, just to show what happens. Here we still have the condyle. It means that you can do posterior condylar approach on this side for pathologies which are lateral but going posteriorly. So we can approach them quite easily. But on this side, you can see that you can go transcondylar, and we have the approach and the easy approach to lesions which are lateral, but also which are going anteriorly. Here showing again the lesion. The idea is, once you have those lesions, the idea is to do an operation and remove them completely. And this is possible. I will show you later on. So here we have this is a drilling of the condylar aspect. You see here we have the horizontal part of the vertebral artery, and we are using actually the diamond part of the drilling, and one has to be very careful. There is quite a good distance between the two, between the vertebral artery and the part which is being drilled. One has to be just careful, and it is possible. Once you do that, and you drill that medial part of the condylar, you get quite a lot of space. And as you can see, once you open the dura, you can see the tumor here, just behind the arachnoid membrane. It's quite easy to spot. And once you remove the arachnoid membrane, you can see very well the tumor. And the trick now here is basically to gut the tumor, and progressively, what do? You gut the tumor, and progressively, you actually dissect it progressively from the surrounding structures. And you can do that without any problem. So here you can see the picture which is showing the area where the tumor was, and the tumor has been removed completely. And when you do the MRI, of course, you have removed completely the tumor. I hope I've gone straight to the point. And let's remember that the anatomical laboratory is the best place to learn surgery. I heard that from Professor Albert Rotten. Thank you very much. I'm ready to answer all the questions. I tried to make it as simple as possible.